So we are really glad to have Professor Kailash Narayan with us today. So Professor Narayan is a radiation oncologist consulting at Icon Cancer Center, Freemasons, bringing over 34 years of experience in diagnosis and treatment of gynecological cancers. Following completion of his medical training in 1973 and a postgraduate degree in MD Biophysics from AIIMS New Delhi, he obtained a PhD in experimental pathology at John Carton School of Medical Research, Australian National University in 1981. Professor Narayan commenced specialist radiation oncology training at Auckland Hospital in 1982 before joining the PMCC in 1984. In 1987, he became a head and neck cancer consultant at PMCC before being appointed as the head of radiation gynecology oncology. He is actively involved in key studies and trials investigating radiation therapy treatments for gynecological cancers. Along with clinical radiology and molecular imaging colleagues, he has investigated the use of MRI and PET in staging and treatment of gynecological cancers, leading to numerous publications in international journals describing the improved results. Professor Narayan has pioneered and developed image-based ultrasound-guided conformal brachytherapy for cervical cancer in collaboration with the brachytherapy team at PMCC, resulting in a better tumor. He is known for his innovative thinking, clear communication, and Professor Kailash Narayan is an experienced radiation oncologist consultant, and we all know him very well. Please, Professor Narayan.
The entree has already been served and the blood has diverted to stomach and the blood supply to brain has dwindled. I would therefore not take much time. I will simply use slides to illustrate some of the principles which I'm going to mention. So the talk is more like a statements rather than trying to explain things. It will certainly raise many questions in your mind, and I think if you start thinking, my purpose would have been served. Now, if you look at the, are you able to see the? You can see the pointer? Yes. Now, these are the rabbit ear chamber pictures, morphology. These are live microscopy. And you can see that hemorrhage in the ear chamber is actually absorbed in these vessels. And these vessels are actually lymphatics. And they are not flowing because they have just got the red cells which were in the interstitium. They have found its place in the lymphatics. This is phase contrast microscopy of a terminal lymphatics, and you can see all kind of tissue debris is being collected in the lymphatics. This is a thyroid graft I was studying in rabbit ear chamber, and these again are intravital pictures. At 28 days, there were a lot of inflammatory changes as the graft was stabilizing, and then the terminal lymphatics, which were already there, became prominent because now they are full of tissue debris. And by 51 days, the debris has all been cleared and the lymphatics have collapsed. So you see lymphatics, the role of lymphatics is to clean the interstitium. So whatever is in the interstitium is cleaned by lymphatics, provided the particular layer of the endothelium is attached with the filaments which are anchored in the interstitial tissue. And here they are shown, the filaments which are attached outside the endothelium. Now imagine in supermarket when you go and unroll the polythene bag is very difficult to separate because it is stuck. And the reason is that a collapsed lymphatics is really a potential space. Now, in order to open, it would be very easy if there were some filament attached on the outside or the polythene, and all you needed to do was to pull them apart. And this is exactly what happens when the tissue debris. Could I request people at the back? I'm getting disturbed by your lot of conversations. So if the interstitial pressure rises, then there is going to be pull on these filaments. So as the filament get distorted, there is a pull and the lymphatics open. So like vacuum cleaner, inside pressure is negative, outside pressure is higher, and paradoxically, because the filaments are outside and they get pulled, the junctions open up and the tissue debris gets sucked inside the lymphatics. So this is how the lymphatics are going to function. Now I have got here the schematic diagram of a terminal lymphatics, and the arrow indicates the direction of the fluid and the debris going in. Now you can imagine that here on this corner is well differentiated endometrial cancer because it still retains glands. It's very difficult that even if these glands get dislodged, that glands are not going to be able to get into the lymphatics. But if you look at the grade 2, there is still possibility some of these cells might get in. But if you look at here, where the serous and clear cell component is, there are lots of tissue debris, and they are very single cells, and they are very easy to get inside. And that's the reason why the poorly differentiated epithelial tissue, which loses the cell contact and are wandering into the interstitium, are easily sucked into the lymphatics. So higher rate of LVSI in high-grade tumor is associated with numerous loose neoplastic cells, and I've already explained that, so I'm not going to read that again. Now the other observation, I was quite struck that many years ago, when the MRI was not available, people used to do the staging of the lymph gland with lymphangiography. And when they did lymphangiography, they were able to see the lymph nodes, and the distortion would tell them whether the lymph nodes are involved or not involved. However, they found that in many cases, not many cases, but in some cases, the contrast actually ended up in the liver or in area where there is no direct connection between the lymphatics and the systemic circulation. So they suspected that there is a connection between the lymphatics and the venous system, but they could not pinpoint and could not figure out where it is. Subsequently, in 2006, the interstitial lymphatico-venous anastomosis was demonstrated by this experiment. And what was the experiment? That ulcer, which is in the feet, and if it is directly located above the bony surface, then there is not a lot of tissue, and that ulcer is very difficult to heal. So they usually have a myocutaneous flap raised from somewhere, and they stitch it on, and then this is how the ulcer is repaired. So these plastic surgeons, when they were repairing, they decided to investigate something quite interesting. So once they anastomosed the arteries to the recipient site, they left the vein of the graft loose, and then they injected 50 micron Why is it essential for you to talk? And if you do want to talk, please go out or ask me to keep quiet. So they injected material directly into the muscle. and the diameter of the radioactive particle that they injected was something like 50 micron. And there is no way that 50 micron particle can get inside the blood vessel, some other means. And since the particle size was such that this was an indirect way of postulating that the lymphaticovenous anastomosis actually exists throughout the body and not just from the thoracic duct into subclavian vein, as is generally being thought. If you look at the incidence of LVSI and grade, you will see obviously that the endometrioid grade 3 LVSI rate is quite high, and it is very interesting that the endometrioid adenocarcinoma, clear cell carcinoma, and serous carcinoma, they have a different molecular makeup, so to speak. But the incidence of the LVSI is more or less similar. And incidence of lymph node metastasis is also similar. The exception, of course, is serous, where the ratio of LVSI to lymph node is a little bit higher compared to the other side. Now, these are 1,427 patients. They were treated all endometrial cancer patient as well as some cervix cancer patient. And I have purposefully included cervix cancer patient here. And the reason I've only included those cervix cancer patient where hysterectomy has been done. So like endometrial cancer, the primary has been completely removed. Now, if you look at this, once the primary has been completely removed, it is squamous cell carcinoma, adenocarcinoma grade 1 and 2, adenocarcinoma grade 3, or clear cell and serous. So do you see from squamous cell to differentiated adenocarcinoma and then poorly differentiated and serous. Now, if you look at the these were treated according to the standard criteria, which was surgery and adjuvant radiotherapy. The patient who accrued were not selected specifically, so you can see the accrual has happened in a straight line. That means all comers has been analyzed. You will see that the pelvic failure is almost similar. It is slightly higher in the clear cell. You will notice that the para-aortic failure is also similar, little bit higher in the clear cell and so on. But if you look at the distant failure, then 11%, 9%, 13%, and then it was a bit higher on this side. But this is quite interesting. Now, mind you, these are also squamous cell carcinoma of cervix is also included. So it is not just endometrial cancer. And you will notice that when LVSI was negative and the nodes were negative, the failure rate, overall failure rate, there was nil in cervix cancer, 3% and 8%. Only it was higher in serous and clear cell. Now, the reason it was probably higher is because the clear cell and serous, they are very much loose cells, and it is quite easy for these cells to escape even physically through the fallopian tube and get seeded in the peritoneum. And many of these relapses that happens, even when the nodes are negative or LVSI is negative, they can happen, say for example, in the upper abdomen. So it's quite likely that this is just a physical passage. But otherwise, you will notice that when the LVSI positive, again, the incidence of relapse is increasing, 19%, 21, 30%, and 41%. And when they are node positive, naturally increases 21, 23. So in other words, squamous cell cancer and grade 1 and 2 endometrial cancer, the relapse pattern is almost similar. However, in grade 3, it is rising, and again in clear cell and serous it is rising. So what I'm trying to say is, simply by looking at the differentiation and the loose tissue, it is possible for us to see that the cells can just disseminate in a physical possibility. Now, this is actually, people think that the blood-borne metastasis can also happen because the cells can enter immature blood vessels in the tumor. If that was the case, and going to the distant metastasis, if that was the case, then LVSI negative and node negative tumor, the larger tumor will have more metastasis, and the small tumor should have less metastasis. Now here are the 528 patients where disease was entirely limited to uterus, because I didn't take extra uterine disease because otherwise we would not know. And when the LVSI was negative, you look at the tumor size, it varied from 0.2 centimeter to 15 centimeter. But median diameter of the tumor was 3.5 centimeter. And if you look at the less than 3.5 centimeter versus more than 3.5 centimeter, there is actually no difference in the relapse rate. So it appears to me that the size actually doesn't matter. If there is no LVSI, then the tumor is not metastasizing. So what I'm trying to say is, in order for cells to get into the circulation, the entry route is through lymphaticovenous anastomosis, because without LVSI, there is no possibility of cells actually getting and sucked into the system. There is no direct possibility of cells getting generally. Of course, you would say that a renal cell carcinoma is seen invading into, let's say, a renal vein, but that is actually a local progression. But general metastasis is necessary for LVSI to be present before it can metastasize. Similarly, if you take the LVSI negative patient and look at the histology and look at the myometrial invasion in absence of LVSI, because these patients did not have LVSI, whether it is inner half or outer half makes no difference. I think because a lot of time has passed, and I just want to present this last slide and then I'll stop. If you look at, these are 1,187 endometrial cancer patients alone, and if you look at the grade 1 and 2, grade 3, clear cell and serous, and if they're all LVSI negative and node negative, the relapse pattern is 9%, 9%, 11%, and 18%. But even so, if you look at the patients who are failing in the pelvis only, they are quite few. And if they do fail, because we might have given just vaginal wall brachytherapy, whole lot of them can be salvaged. But most of the patients who fail, they have a distant component. And interestingly, as we go further with LVSI positive and node positive, the failure rate start to increase. But if you look at the LVSI positive and node positive, or any LVSI but node positive, then grade 3, clear cell and serous have similar patterns of failure. And if you look at the patient, the proportion of patients who are failing outside pelvis, almost all of them have nearly 80 to 100%, they are failing actually outside pelvis. So where we are giving treatment, the current method of treatment, which is surgery, and if indicated post-operative radiotherapy, is giving excellent control in the loco-regional site. The only patient, even when they are failing, most of them are actually failing outside pelvis. I'm sorry I had to be somewhat rushed, and sorry to have lost my temper, but it's somewhat disheartening if you come all the way far away and you're asked to give something and explain something which you think you have put in an effort so that people can understand. Sorry about that.